Great. So welcome everyone to the July Sign Up Centre lecture. It's going to be delivered by Dr. Pat Sartori, who is a consultant in paediatric palliative care and has a wealth of experience through her career of addressing the medical complexities of a lot of the children we see with neurodisabling conditions. Today's talk will be focused more on the gut and gut failure. And looking through Pat's slides, they include feed intolerance, neuropathic enteropathy, GI dystonia, dysmotility, and visceral hyperalgesia. So really looking forward to hearing more about Pat's talk, and I'll pass you over to her.
Hello. It's nice to sort of see you all. I'm sharing my screen now, so hopefully it will. There we go. So there's usually a little bit of a delay, but then it appears. Thank you, Ben, for asking me to do this presentation. So what I want to talk about is sort of the interface between neurodisability and palliative care, which I've really been exploring since I started doing palliative care about 12 years ago, and trying to define where the areas are where we need to work collaboratively. And I'm going to focus on gastrointestinal failure, both because I think it's quite a topical and challenging syndrome to deal with, but also because it's quite a good paradigm of how neurodisability services and palliative care can work together. So just a very sort of quick reminder or overview of what the interface between neurodisability care and palliative care is. And clearly this is the severe end of neurodisability, and it's children who have multiple disabilities and complex health problems and often complex symptoms. And palliative care has a number of roles to play. One of them is obviously in end-of-life care. And we all know that children with severe neurodisability and complex health problems have a life-limiting condition, and they may die during childhood. And providing good quality, supportive end-of-life care in the place of the family's choosing is one of the things that we specialise at. But it's not just about end-of-life care, because we all know these children are very vulnerable, that their trajectory is unpredictable, and they can have life-threatening acute deteriorations. And we sometimes get involved in supporting advanced care planning, supporting families on a sort of either a long-term or a short-term basis, negotiating access to acute services, but also supporting them with symptom management at home where that's appropriate. And I think we come into our own when it comes into management of complex symptoms, and that can be sometimes, as I say, long term, and sometimes it's just a matter of doing some work, identifying some appropriate drugs and effective management, and then maybe we can fade into the background again. And as well as that specialist input, there's also the generic hospice support for families with short-term breaks, emotional support, nice things, and so on. So it's quite a complex offering, really. So I'm now going to move on to talk about gut failure, and I'm anticipating that the scenario I'm going to discuss is fairly familiar to most of you. And as well as giving you some of my thoughts and a few sort of points of reference in terms of published data, of which there is not a lot, I'm also going to base a lot of it on anecdotes, patients that I've looked after, and kind of my experience. All of the patients I mentioned, I have changed their names. I've just randomly allocated a different name. So the first patient I'm going to talk about is somebody I'm going to describe as Sam, who was referred to me 7 or 8 years ago. Whoops, sorry, there you go. Sorry, I suddenly had a whole load of vignettes in front of it. Okay, I hope you can all see my slide again. He was referred to me about 7 or 8 years ago by the epilepsy team at Great Ormond Street, because he lived outside the catchment area for their palliative care team for non-oncology, and I don't really have a catchment area, so I accepted him. And this is a 12-year-old boy with severe cerebral palsy, with severe global developmental delay, non-mobile, non-verbal, complex seizures, movement disorder, more hypertonia than dystonia, musculoskeletal problems with scoliosis and hip problems with secretion management, recurrent infections, particularly chest, but also some systemic viral infections, flu and so on. He'd had a few admissions to PICU before I met him. He had a lot of gastrointestinal problems with chronic constipation, reflux, and was fed by PEG. And the referral to me was because he had exhibited pain and distress and hypersensitivity, in that loud noises and bright lights and things would sort of set him off and upset him. But also he clearly had feed intolerance and malnutrition. So at 12 years of age, he only weighed 25 kilograms, and he had pressure ulcers on his ankles. As you can see on the right, there were already a large number of ologists, specialists involved in his care. So neurology from Great Ormond Street, gastroenterology from Addenbrookes, paediatric surgery, I think was mainly Addenbrookes, community paediatrics locally, and acute paediatrics locally, orthopedic surgery in Stanmore. I can't remember where the ENT surgeon was. And then we add in palliative care to this mix. So at this point, I just wanted to sort of ask if any of you have experience of, what I'm going to try and do is unshare the screen so that I can, actually, I don't think I need to do that actually. Right. So I just wondered if anyone has any questions. I think Ben was going to moderate questions.
Yep, I'm happy to, if people can either type the questions into the
questions
messaging.
or sort of, really, I'd be quite interested how many of you have seen this kind of presentation in patients like this.
I think personally, a lot of the case that we have complex cerebral palsy and autism, actually, with a lot of children with sensory processing problems allied to the gut issues you've mentioned, in terms of absorption of nutrition, but also the hypersensitivities that you raise, Pat.
Yeah. Okay. Actually, I think I can probably, I'm not seeing faces. I think I'll just carry on sharing my screen, because otherwise it just gets a bit, hello, Camilla. Right. So I'm just sharing my screen again. Okay, I'll carry on. So obviously I was referred this child, and I was thinking, I was drawing on my experience, and I at this point I'd had a really negative experience of feed intolerance in children with neurodisability. And there were two children that I remember who were referred to me right at the beginning of when I switched from being a paediatric oncologist to doing palliative care. And these are both referrals from Addenbrookes. Both were on D2. The first one was a 13-year-old girl with a very similar constellation of symptoms and severe cerebral palsy, who had been an inpatient for, I think, a couple of months, presenting with pain. With abdominal pain. She'd had surgical intervention, she'd been scoped, she'd been investigated, and she still had unexplained pain. And I was called in to try and rationalize her opioids. And I met her on one day, and I started rationalizing the opioids. And when I went back to see her the next day, she died. And she'd developed severe pain, become profoundly acidotic, and died very, very acutely. And although it's a bit dramatic to say she died of pain, we really had no explanation. And then not long after that, I was referred another boy who was about 15, very similar story, not actually a local child. They'd moved around quite a lot, but he was an inpatient. And I walked in to find mum and one of our lovely dietitians both in tears, because he didn't want any feed because it hurt. He didn't want any food because whenever he was fed, it hurt, and his mum wanted to stop the feed. And yet, of course, as a dietitian, we wanted to feed him and to meet his calorific needs. And it was a sort of dreadful kind of situation. And again, he had very similar symptoms, and they then actually had a booked stay at the hospice in Oxford, which is where they'd originally come from. So he went back to Oxford and was stabilized there, but then eventually died. And along this course, at one point, he actually pulled out his gastrostomy as a protest against having feed. So the thing that struck me is this concept of severe pain being caused by normal physiological feeding. I then found my attention was brought to this publication by Harold Seiden in Canada, which described something very similar to what I was seeing. And basically, this was a retrospective review of 45 patients who died in their hospice or palliative care service, all with non-oncology diagnoses, looking back over 5 years. And of the 45, 15 had symptoms of what appeared to be progressive enteral feed intolerance. And they presented with reflux, vomiting, bloating, ileus, irritability, and pain. And the episodes became sort of repeated, more protracted, and became a sort of definite phase of end of life. And certainly when Harold Seiden published this, he was thinking that it could be a marker of kind of end stage disease in these children with severe neurological conditions. And I think of the 15, I think 14 of them had neurological conditions and 1 had something else. But it was very much presented as a sort of end stage terminal condition. And since then, we've kind of become aware that, that this is a very real phenomenon, but actually that it is more widespread and that there are milder, more moderate, intermittent versions where children present with symptoms intermittently, but actually can go on and off for many years with these kind of symptoms. And so we've kind of widened our definition and our awareness. And there are lots of competing not definitions, but nomenclature really. And Harold Seiden called it enteral feeding intolerance. In palliative care in the UK, we tend to call it gut failure. I think that's fairly sort of easy shorthand, although it's not the same as gastrointestinal failure as defined in terms of nutrition and feed tolerance that's used in gastroenterology and nutrition. I put gut failure on a death certificate a couple of years ago, and that was turned down I wasn't allowed to put that by the registrar, but I then just turned it into Greek and called it neuropathic enteropathy, which is the same thing but in Greek, and that got passed. I actually quite like the terminology of neuropathic enteropathy because I think it describes what I think is the mechanism. And the British Society of Paediatric Gastroenterologists is actually looking at drawing up a guideline to manage this syndrome, and they've labelled it gastrointestinal dystonia. And this is a working definition which they have, which is about to do a Delphi process. And it's a recognition that many children with severe neurodisabling conditions have problems with feeding and bowel habit. And we all know most commonly reflux and constipation. And in some children, the symptoms are much more diffuse throughout the gut. And when they're severe, they suggest that it reaches a threshold where it could be defined as gastrointestinal dystonia. And I think the description of the clinical manifestation here is very good. Clinical manifestations of distress, including pain behavior, hypertonicity, retching, vomiting, autonomic phenomena, and abdominal distension. And having excluded other causes. And this is very much the phenomenon that we're looking at. And also the Association of Paediatric Palliative Medicine is also trying to draw up a guideline to support the management of this. And we're trying to collaborate with the British Society of Gastroenterology so that although they may be complementary guidelines, they shouldn't be contradictory. So again, an opportunity for anybody to ask questions. Ben.
I don't have any questions for anyone so far, but I think that's a really valuable, those last few slides and its relevance to a whole spectrum of different children we see in the clinic, not just with cerebral palsy, but with autism and other conditions which are all linked by a dysregulated sensory processing and this visceral hyperalgesia, which I think you'll come on to talk about. Any questions from anyone else?
May I make a comment? Is that okay? Since those earlier experiences, I think we have learned a lot, and the communication between the clinicians, the therapists, and the families, I think, has probably moved things on hugely. to the extent that the parameters at which the interventions are made are much more likely to leave the family feeling that their care has been kind, rather than set at high levels of intervention. And that would be my comment were I to be in the position of feeding a little boy or young man again, I think. And that's how I've worked since. And it's been very helpful. Yeah, I'll leave it at that.
Yeah, no, I mean, those two children were a real kind of learning experience for me as well, because I had never seen anything like it. But since then, obviously, we all have. Yeah. Okay, thank you. Thank you very much. Shall I carry on? Okay, hopefully you can see my screen again. What I'm going to do next is sort of talk through the pathophysiology, because having sort of looked at the literature and looked at my experience, the next thing for me before thinking about management was to try and understand the processes and the physiology behind this, so that I could try and think of some interventions. And I mean, interestingly, I think a lot of us were thinking in parallel ways and got to the same place in the same way. And this is part of the process of symptom management, is to try to understand the pathophysiology and then look at understand the mechanisms and then look at interventions. There are potentially multiple mechanisms, and I'm not going to sort of dwell on all of them. There is the whole issue of gastrointestinal dysmotility. There is visceral hyperalgesia. There is the part that prolonged artificial feeding may play in gut dysfunction. And, these children are often on multiple medications with lots of, anticholinergics and anti this and anti that. And, that may well interfere with innovation and add to problems. And you can probably think of other mechanisms that play a part. So I'm going to talk about gastrointestinal dysmotility, and I'm going to say thank you, Camilla. I've stolen some of your slides. They've been very useful. The first slide the first point I want to make is just a reminder that the gut has an intrinsic nervous system which coordinates reflexes, peristalsis, etc., which consists of 500 million neurons, 5 times more than the spinal cord. So it is a very, very much a nervous organism. This is also modulated and interacted by the autonomic nervous system. So both sympathetic and parasympathetic interplay with the intrinsic nervous system. So it is very much a neurological organ, and therefore thinking about it in terms of neurology is quite helpful. Now, we all know that children with severe neurodisability can have a range of different areas of the gut where they experience dysmotility. Oral motor impairment, which affects swallowing and feeding, esophageal dysmotility, gastroesophageal reflux is very common, antroduodenal dysmotility, a bit less so, constipation, very, very common. And then, and in some children, the whole gut is slow and basically uncoordinated and exhibits dysmotility. And then because of that, you have secondary pathology. Because of sort of slow, distended gut, you can get bacterial overgrowth, particularly following antibiotics. And of course, because these children also are more prone to chest infections or UTIs, they're also more likely to be exposed to antibiotics. And I mean, the other thing that they often describe is overproduction of wind and bloatingness. And the part that fermenting sugars hanging around for a long time may play in that, particularly with artificial feeds and with medication that has sugar in it. So there's a lot of secondary pathology that may follow on from this slow motility. And the other aspect of the gut being a nervous system in itself is the experience of pain and this concept of visceral hyperalgesia. Now, it's a recognized phenomenon in sort of children without any pathology. It can follow a gastrointestinal infection, and children can have a period of really what appears to be unexplained abdominal pain following some insult, and overlaps with the concept of functional abdominal pain. I don't know whether that phrase is still used or whether it's fallen out of fashion, but there is clearly an overlap, and in a way it serves as a sort of model for explaining so-called functional abdominal pain. But the experience of visceral hyperalgesia is much more common and more recalcitrant to treatment and persistent in children who have underlying neurological disorders. So thinking about, here I was thinking about what to do with this child, Sam, he's still there. And I heard a talk by a neurophysiologist about long-term modulation of pain pathways. And she gave a very, oops, what's happened? Sorry. I hope you can all still see the right slide. She gave a very sort of scientific talk about how the pain system develops. And sorry, I keep, oops a daisy, sorry. Right, sorry, I keep losing my slides. I don't know what you're seeing on your screens. Hopefully we're back to what we should be.
You can see the pain pathway slide, long-term
yes,
modulation.
Lovely. Yeah. Okay. So she talked about how the nervous system and the pain pathways in children are plastic and how they are modified by experience and exposure to pain. And she described a study in healthy adult volunteers who were all given a consistent pain stimulus and then asked to score the severity and to indicate the severity of pain. And what was interesting is that the volunteers who'd had a significant history of significant pain during childhood were not more stoical. They actually experienced pain that was more severe and felt over a greater anatomical extent than those who hadn't, suggesting that the experience of pain makes you more sensitive to pain later in life. And there are some models, particularly of understanding in the somatic pathways to explain this. And so I'm just going to briefly explain the idea of central sensitization and hyperalgesia. So you have pain nociceptor activation, so a painful stimulus into your first order neurons, and then which then release glutamate. These particular neurons release glutamate, which is picked up by the NMDA receptor in the dorsal horn of the spinal cord. If you have prolonged activation and prolonged glutamate release, the receptors become more sensitive and more numerous, which means that the second order neurons become hyperexcitable. So obviously the same stimulus as before becomes felt as more pain because the signal to the brain is amplified. And so in an analogy with that, I think we can see that the visceral nervous system may well have a sort of similarly analogous process. And I've looked at some analogies here, what happens if you have brain damage. In the peripheral nervous system, you get loss of function, you get weakness, you get abnormalities in tone, you have spasticity, you have involuntary spontaneous movements, dystonia, and then you have secondary skeletal deformities and pain. In the visceral nervous system, you have loss of function, you have weakness, the equivalent of that is dysmotility, you have secondary changes with distension, you have chronic pain and discomfort, and then you have visceral hyperalgesia, which I think is analogous to central sensitization. So I'm going to move on to the thought that maybe prolonged exposure to artificial milk-based feeds may also contribute to gastrointestinal dysfunction because children who are unable to swallow and who are fed enterally are often fed on milk-based feeds, and this is not what they would normally be eating. And so there are questions about the osmotic load, highly processed, possibly greater transit, etc., etc. And there has been a move over the last 10 years probably towards blended diets, so giving them normal food blended to a consistency that you can put down a tube. And I know there's a huge amount of interest, and I'm not going to talk about that at great length because I really will run out of time. Again, just wonder if there's any questions.
So I had a question from Dr. Swaminathan about the GI dystonia, actually, Pat, saying if there are any clear definitions for that terminology set as yet.
Well, this is the draft definition is the one that I shared on that slide from the British Society of Gastroenterology. So if you go, it's in the. I'm happy for you to share my slides with people afterwards
Okay.
as well, obviously, and they're on the recording. But so yes, I mean that definition it's basically a description of symptoms. It's a description of distress, which is associated with otherwise normal physiological gastrointestinal processes such as feeding, peristalsis, pooing. So I mean that's. So that's the definition that's going on. But I mean, clearly that's going to go around a Delphi process, so that may be modified.
I think I had a question regarding, we were talking about glutamatergic signaling and its relevance to kind of excitation, inhibition, imbalance. And a lot of the children that I see have profound anxiety as well. So it's intrinsically linked to the gut in terms of that balance between overexcitation as well. So it's very, very difficult to manage because you have these children who are on lots of medications anyway, anti-seizure medication, which also address that difficulty, but also then on top of that have the additional stress of the lived experience within the world. So very, very interesting point.
Okay, shall I carry on? Okay, so which brings us to interventions. Wait, what's happened? Sorry. Right.
We can still see that fine. That's
fine. Okay. Well, before having any interventions, clearly we need to make sure that we do take a careful history and assess symptoms. Try to identify which are the predominant symptoms for each child because they do vary. And then make a rational choice of medication. It's therefore important, subsequent to that, the sort of palliative care approach is very much to titrate that medication carefully, to have ongoing regular assessment of the response, and support the family as you make those interventions. And one of the things that is really helpful is having regular home follow-up by one of the clinical nurse specialists from the symptom management team, because then you get weekly real-time feedback as to what's going on, and that can really help in terms of tweaking the management. And we can also offer short stay in the hospice for symptom management and observation, which can be really helpful. So in terms of what interventions, well, we need to manage these acute episodes because they certainly, to start with, they're intermittent, and in between patients are okay. Sometimes we need to manage bloating, distension, wind. Some of them we need to manage nausea, vomiting, retching. We need to manage pain, and interventions for any one of these can actually have overlapping effects. So it's not clear cut, although I'm going to go through them one by one, and then I'm just going to mention GI bleeding and nutrition as well at the end. So first of all, I'm going to talk about management of acute episodes. And families, a lot of families find for themselves empirically that gut rest often works for an acute episode. So they stop the feed, put them on clear fluids, and things settle down, and then they gradually regrade them and reintroduce the fluid. And they rarely need analgesia or antiemetics during these episodes. Sometimes they do, but sometimes just clear fluids is enough. I also, over the years, have sort of looked at the idea of using particularly metronidazole. If a child has had a recent antibiotic exposure and they may have bacterial anaerobic overgrowth, and using metronidazole to sort of rebalance that. And occasionally that's helpful, but it doesn't actually deal with most of these episodes. It's not really of great value for the recurrent episodes because they probably aren't antibiotic related. And clearly, in terms of prevention, the sort of blended diet and other dietary manipulations in terms of rate and volume of feed and so on can also have an impact on children's tolerance for feeding. Then in terms of managing sort of bloating, distension and wind specifically, parents can vent, they can withdraw gas. We try sometimes to avoid fermenting sugars. Unfortunately, this generally means switching from syrup from medication as syrups and suspensions to tablets and crushing them because they won't have the fermenting sugars, and then finding ways of giving those. So that's quite an undertaking, but for some children that can be quite helpful. Again, the blended diet can be helpful with this, but again, I mean, bloating and distension will often respond to analgesics and antiemetics. So I'm going to come on to management of nausea, vomiting and retching, and I'm going to give you a whistle-stop tour of antiemetics. One of the things that families do is adjust the volume and rate of feed, and that can help. Otherwise, we have a whole load of antiemetics available, and I'm just going to run through all of them. So cyclizine may seem a good candidate because it's centrally acting anticholinergic antihistamine drug, which works in the vomiting center, because the vomiting center is the part of the brain that coordinates vomiting. Basically, it receives all the inputs from the various things that stimulate vomiting, and then it coordinates the actual reflux so that you can vomit safely hopefully without inhaling. Although of course that is a risk, but that's what the vomiting center does. It's like the final common pathway for vomiting. And the receptors that are commonest there are the muscarinic and histamine H1, and also substance P, which I'll come on to a bit later. And it's mostly if you block these, it mostly affects vomiting of central origin, so raised intracranial pressure, which is something we come across with children with brain tumours particularly, but also vagally mediated vomiting due to gastrointestinal distension or inflammation, which kind of sounds very much like our population. But in fact, they're often already on a lot of drugs with anticholinergic actions, so they're already fairly anticholinergic, as it were, and also have quite a lot of anticholinergic toxicity. I do wonder whether it exacerbates the dysmotility, and haven't found it to be as useful as you might think. So let's move on to the chemoreceptor trigger zone, which is another part of the vomiting mechanism. It's an area, it's a part of the fourth ventricle in the area postrema, where the brain can actually sample what's circulating in the peripheral circulation, where the blood-brain barrier is suspended. And so this is where molecules such as drugs, things like antibiotics, opioids, other drugs that are emetogenic, also toxins from liver failure, renal failure, GI obstruction, where you maybe absorb stuff that you wouldn't normally absorb. And these can all trigger vomiting via the chemoreceptor trigger zone. The major receptor there is a dopamine 2 receptor. And so metoclopramide is a central and peripheral dopamine 2 antagonist. So it acts on the chemoreceptor trigger zone. It also acts on the stomach. It's a prokinetic. And there are some anecdotal effects of it being effective in children with GI failure, although I myself haven't used it, but it's something that some of my colleagues around the country use. There is a problem with it causing dystonia. Anything that interferes with dopamine can cause dystonia, and we all know that that's commoner in younger people and children. So I've just mentioned haloperidol, which is the most potent dopamine antagonist. And we very rare, there's wariness in using it because of the risk of dystonia, although there is actually evidence that if you use it at very low dose, well below what's recommended, it can still be effective as an antiemetic in children who've got a metabolic cause for their vomiting. And I don't know whether it has a role in GI failure. I've just put it up there to ask the question. The antiemetic I use most frequently in this context is levomepromazine, which is a very broad spectrum antiemetic. It has multiple actions. It has some anticholinergic, it's a dopamine antagonist, and it's also a 5-HT2 antagonist, and acts at both the chemoreceptor trigger zone and the vomiting center. It's also a sedative, but if you introduce it slowly, the sedation kind of wears off. One of the reasons it's useful is you can give it via multiple routes. You can give it orally, you can give it IV, you can give it as a subcutaneous infusion, and because it's a small water-soluble molecule, you can give it buccally. And I came across it buccally in a young man who I'm calling Mickey, who'd had a liver and gut transplant for a rare condition, and who was mostly on parenteral nutrition, but was gradually transitioning to enteral nutrition, but who had episodic vomiting. And when he vomited, he obviously wouldn't tolerate oral medication, sorry, I've lost my screen again. Right, sorry. And although we had him on regular levomethomazine, when he had these episodes of vomiting, it wasn't going in. So we tried him with buccal, and it really worked. It really helped with those episodes of vomiting, and he felt much better. And I think over time he has gradually transitioned to a normal diet, to an enteral diet, and has been able to go back to school and has actually done very well. And so when I met Lenny, who's a young man with Noonan's and multiple lentigines, this experience came to mind. Now, Lenny had a most unfortunate story. A tree branch fell on his leg and fractured his femur, and he was admitted to Addenbrookes for surgery, and then had a really, really stormy post-op course with big GI bleed and acute gut failure, and ended up on parenteral nutrition. And a year later, he was still on parenteral nutrition, and any attempts to feed him made him vomit. And when he vomited, his dystonia was exacerbated. He had pain, he didn't sleep, and he was referred to us for end-of-life care because this was intractable. And so I started him on levomethomazine regularly orally, but also suggested using buccal during episodes of vomiting. Now, he was actually oral averse, and so buccal wasn't going to go anywhere. But Mum, because she was doing home PN, was IV trained to a very high standard and was able to give him IV levomethomazine during his episodes. And he actually and whether it was the levomethomazine, whether we tided him over that period, but he did actually stabilise and gradually introduced more enteral feeds, and has now very successfully transitioned to adult care. So coming back to my list of antiemetics, I mentioned substance P, which is a key transmitter in the vomiting centre, and there is a drug which is an NK1 antagonist, which is aprepitant, which has been out for probably about 10 years, and it's licensed for chemotherapy. And there are anecdotal reports from the GOSH team that it may be effective in children with this gut failure that we're describing. Again, I've not come across any published evidence, and I haven't used it, but I think it's one to bear in mind. It's also very expensive, and you have to do all these complicated forms to get hold of it for anything other than its license. And then speaking of other things that are licensed for chemotherapy, ondansetron, which is licensed for chemotherapy, which is another antiemetic which works on yet another receptor, 5-HT3, both on the vagal nerve terminals and centrally in the chemoreceptor trigger zone. And as well as being licensed for chemotherapy, it's also licensed for gastroenteritis and cyclical vomiting. So I think it may play a part sometimes for some of these children. And I sometimes inherit children who've been already started on ondansetron, although it doesn't tend to be something I start them on. And then we have alimemazine, which is a phenothiazine-derived antihistamine, known as Valagan. I came across this as a surprise. I was looking after another young boy with a very similar set of symptoms, who I've called Ali, with persistent abdominal distension and vomiting, who'd had anisins. And I met him once, and I was working up a symptom management plan. And in the meantime, he had a review with the gastroenterology team at Great Ormond Street, who started him on alimemazine. And next time I saw him, his GI symptoms had completely resolved. So I Googled it, and I found this rather nice randomized double-blind trial from Great Ormond Street, looking at the effectiveness of alimemazine in controlling retching after anisin fundoplication. And I don't know whether I've got time to go into this mechanism or whether you want me to skip on, Ben.
It's completely up to you, Pat. I'm enjoying the lecture, so I'd like to keep going, but
okay, I have packed a lot in. But yeah, okay, I will carry on. Okay, I'll go back to my slide, because I was again interested in the mechanism of alimemazine, because I thought that's a little bit odd. So sort of to go back a step, the important thing is this concept of gastric accommodation. So the stomach has stretch sensitive mechanoreceptors and osmoreceptors and chemoreceptors. And when they're stimulated, it triggers a vagally mediated vomiting reflex. And obviously, if you've had anisins, you can't vomit, so you retch, which is even worse because there's no relief from it. But normally, the stomach will relax and it will accommodate increasing volume without increasing pressure. Now, what happens with fundoplication is that it can interfere with gastric accommodation. I mean, there may well be some damaged or sensitization of vagal afferents, but it uses up quite a lot of the proximal gastric muscle to make the wrap, and therefore reduces the stomach's volume and ability to stretch. And it therefore becomes more volume sensitive, more pressure sensitive. And the idea is that feeding can trigger the emetic reflex and cause retching. And this is more common in children with severe neurodisability. And it's thought that Nissen's unmasks the underlying neurophysiological dysfunction. And again, management of retching post-fundoplication, blended diet, that's a cure for everything. Obviously, people adjust the speed and volume of feed, but this study showed that low-dose alimemazine is actually helpful, and it's very effective. It's a phenothiazine derivative. It is both a histamine and a dopamine antagonist, which seems to work in the chemoreceptor trigger zone and the vomiting center, and maybe also has a peripheral action and seems to interfere with this vagally mediated emetic reflex. So I did wonder, whether we can extrapolate it wider within our population. Clearly, a number of the children we look after have had Nissens, but not all of them. And there are other mechanical and anatomical distortions of the stomach, which we may inflict, which nature may inflict, which can reduce gastric accommodation, such as having a peg. I mean, that, having a gastrostomy tethers your stomach to your skin, and potentially may distort it. Scoliosis can distort it. And then in addition to this, we've already discussed the neurophysiological dysfunction, dysmotility, and interference with function. So all of these things may produce the same kind of symptoms, even in children who haven't had Nissens. Again, I'm going to pause for breath. Any questions?
So I have a question from Dr. Swanepoel. That she has patients with cyclical vomiting syndrome, which really impacts on his quality of life and family's quality of life, and trying to think about the underlying mechanisms for CVS, especially within this population where it seems to be more common. And as you mentioned before, medications to manage CVS.
Yes, I mean, I think if it's clearly cyclical vomiting, then there's maybe worth, I don't know what you've tried, but it may be worth a trial of ondansetron, because that is licensed for cyclical vomiting. I haven't specifically looked at that, and I haven't looked at the evidence, but if you haven't tried that, that may well be worth it. I mean, otherwise, I would always go for levomepromazine as my first choice antiemetic in this kind of situation. But look and see if there's any other symptoms.
I've actually got a child on a Prepitant who has CVS and is peg fed, and it was started by the Sheffield gastroenterology team, and she's been tried on a number of different medications for CVS, including cyprohepatidine and also ondansetron, and it's actually really been helpful.
With a Prepitant.
A Prepitant.
Yeah.
And that's the only child I know that's been put on it, but for her CVS symptoms, it's really helped.
Yeah. I mean, I would certainly work my way through those and consider that. Yeah.
Any other questions? One from Naomi. So it's whilst taking into account the practicalities, cost, patient willingness, and time training, do you think we should be considering blended diet a lot earlier, before artificial milk feed, or even when our own children have been on long-term feeds to prevent ongoing gut issues?
I think that's a really interesting question. I don't know the answer. I think there's a lot of interest among the dietitian world as well in blended diets. I don't know the answer, but I think maybe yes, we should consider it earlier. But yeah, I think that's a really good question. Camilla.
Hi, just I feel called in. Blended diet is not the panacea for everything, and there are some children that do not tolerate it because it requires a large volume, much larger than the commercial milk preparation. And I think that the fact that we have we're all very keen on it, me included, maybe comes also with lack of experience. So we have much less patients treated with blended diet than we have with milk, and we select those patients carefully. And there might be that those are the ones that do really well, but I don't think it's for everyone due to the volume and the accommodation issues that you've just mentioned.
Yeah, thank you. Okay, I'm going to stray back into an area where my knowledge is a little bit more up to date. Whoops, hold on. Okay, I'm going to talk a bit about management of pain, and I'm going to run through these drugs. First of all, antispasmodics. If a child is experiencing what looks like colic or colicky type pain, it is quite tempting to think about using Buscopan or hyoscine butyl bromide because it does reduce excessive peristaltic spasm. But the problem is, are we looking at a child who's got excessive peristalsis, or are they experiencing hyperalgesia? In other words, have they got normal or even subnormal peristalsis and they're still experiencing that as pain? And would antispasmodics exacerbate dysmotility? So I have tried them in a few patients. Again, not necessarily the answer. So let's just look at analgesics, and don't look at the detail of this. This is just to say that the majority of analgesics act centrally. So let's start with opioids briefly. This is just a reminder that the pain pathway has two aspects to it. The ascending one, taking the signal from the periphery up through the spinal cord to the brain, that there is a pain stimulus, and then the descending part, which actually interferes with, at every point, with that signal going up to say, no, you're not experiencing pain. And this if you look at the green coming down, it goes through all these parts of the midbrain and the medulla with fancy names like periaqueductal grey and dorsolateral pontine tegmentum and rostral ventral medial medulla. These are all the places where there are concentrations of opioid receptors and endogenous opioids. And what opioids do is basically enhance those endogenous opioids. And at each point, what this does is it interferes with the signal going up and reduces the sensation of pain. Opioids, as we know, are a very effective analgesia. We also know that they cause constipation. Inevitably, because there are opioid receptors on the gut which slow it down. It's almost not a side effect, it's an intrinsic action. And we also worry about having children on opioids long term because of tachyphylaxis and tolerance and the fact that you might need to increase doses and so on. And I've also got a cautionary tale which may or may not be due to opioid, but this is a young woman who I'm going to call Ellie, who was a young woman with cerebral palsy who presented with hip pain. She'd actually been, when I first met her at 14, she was well-nourished, well-grown young woman. She'd previously very stable. She'd had no GI issues at all. She'd experienced some very mild trauma on holiday where her hoist had broken and her parents had to move her manually. And following that, she had persistent pain, which seemed to be localized to her hips. And she'd had this pain for a long time. So we tried her with some very low dose oral morphine. Although it helped a bit with her pain, she became severely constipated. And even though we stopped it very quickly, her constipation persisted and it became severe and intractable. And then she rapidly developed intolerance of feeds, progressive gut failure, and then died very acutely. And this is certainly very alarming to wonder what part the exposure to opioids may or may not have played in this. It's an anecdote, I don't know. But I'm generally been wary of opioids. So that brings us on to the agents for neuropathic pain, which makes sense if you're talking about visceral hyperalgesia. And gabapentin is the first-line medication for neuropathic pain for lots of causes. It blocks the voltage-gated calcium channel in the and reduces the release of neurotransmitters. I'm going to show you a diagram because it's probably easier. This is, again, it's another version of the same diagram. So the red line is the nociceptive neuron from the painful stimulus to the dorsal horn and then up the spinal cord to the brain. And here is the descending pathway. If you look on the right, the orange neuron is the one that's coming from the periphery, so that's the nociceptive neuron, and it's releasing its transmitter, which will then stimulate the postsynaptic neuron. And on this incoming neuron, there is a voltage-gated calcium channel which is blocked by gabapentin and pregabalin. So what gabapentin and pregabalin actually does is it stops that painful signal from ever leaving that first neuron. So that's how it acts. So I'm just going to get back to Sam. If you remember, Sam was the patient who started all this off. And so my first thought, because he had pain and he had these painful ulcers, was to try him on a buprenorphine patch, which is a low-dose opioid. But he didn't poo for 10 days, and his mother said, no, never again. Very forceful lady. So I started him on gabapentin, having gone through all these thought processes. And about a month later, she rang me about something or other. And then I said, how's the gabapentin? And she said, gabapentin, wow. Which I wasn't expecting, because she was a fairly cynical lady by this stage. But basically, his feed tolerance had improved, his hypersensitivity was better, his pain behavior was better. And over the course of next year, he gained 5 kilograms. So I've put 20% there. It's 25%. He was 20 kilos when I met him. No, 25 kilos. Yeah. Anyway, he went up to 30 kilos. His ulcers healed. His sleep improved. He got to school more. It wasn't miraculous, but it was very impressive. And I think at this point, when I met him, he was being considered for jejunal feeds because of the concern about poor feed intolerance and poor weight gain. And actually, he remained on PEG feeds. He's never had a jejunostomy. And so just to bring you up to date with what's happened to him longer term, I mean, it wasn't a miracle. His symptoms have recurred intermittently, and I very gradually increased his gabapentin. But when we get to the top of the gabapentin dose range, each increment has less and less benefit because the absorption is saturable. So beyond a certain point, you're not going to get any more benefit. Switched him to pregabalin, which is not saturable, but haven't seen a huge impact. His episodes have become more frequent and more prolonged, but I have very recently started him on alimemazine, which he seems to have responded to. He is 19. I have transitioned him. But I do still get calls. That was certainly a win for gabapentin for many years. Then looking at other neuropathic agents, I mean, amitriptyline was the sort of go-to. Amitriptyline and carbamazepine were the go-to for neuropathic pain before gabapentin came along, and it's now really amitriptyline is second line, low dose. You don't need to give. It doesn't need to be an antidepressant dose. And I put the same diagram on because if you have a look alongside the nociceptive neuron and the postsynaptic one, there is this inhibitory neuron, which is part of the descending inhibitory pathway, and that's a noradrenergic neuron. So by inhibiting serotonin reuptake, you amplify the input from this neuron and inhibit the signal going from the nociceptive neuron to the postsynaptic neuron. So again, that's something that has potential role in gut failure. Then a few other drugs. I mean, clonidine, which is another adrenergic agonist, which acts in the spinal cord and inhibits the ascending pain pathway, and we're familiar with using it for dystonia, may also play a part. And it's available as a patch as well as oral, so that's certain advantages. I think we worry about it causing postural hypotension. I think when you're looking at this really severe population of really severe neurodisability who are non-ambulant, I think the risk is very low because they're not going to get postural hypotension unless they're put in a standing frame. But I think we can kind of introduce it gradually and start them at home low dose. And I know you, Ben, have used clonidine with a number of patients and started at a very low dose very successfully. So that's another one to consider. And I'm going to mention cannabinoids because families often ask about this. Unfortunately, we don't have any evidence of their efficacy in chronic neuropathic pain, and cannabidiol, CBD, is licensed for use in refractory epilepsy with clobazam in these two very specific epilepsy syndromes, and parents often obtain cannabis oil commercially on the internet. The problem with that is it has unspecified mixtures of CBD and tetrahydrocannabidiol, which is the psychoactive component. And there are concerns about the effect on developing brain and mental health with long-term use. And I would have thought those concerns are even greater in a child who's already had insults to the CNS. But it's probably a question that we get asked. Okay, any questions?
Any questions? And there's the messages on the chat. If anyone has got any.
Sorry, that was a bit of a roller coaster ride. I didn't show you any diagrams of opioid receptors.
So Emma Williams, question: Have you ever seen naloxone used in children? We
did try to use it in this young woman who presented very acutely with opioid-induced constipation and gut failure. It was surprisingly hard to get hold of, but certainly if I wanted to, if I felt that opioids were really necessary and the constipation wasn't responding to the normal stimulants, I think that would be definitely something to consider. Is that your question, or was it using them off license? Because they're licensed obviously for opioid-induced constipation that hasn't responded to first line. Okay, thank you. Sorry, my phone buzzes every time there's a message.
The other question I had, Pat, was certainly in children with dystonia, and has been a big trigger for general dystonia is GI pain and bowel habit. So using medications for dystonia could be augmented by obviously helping more with the gut. But if you can choose a medication that can do both, then you're onto a more of a winner, aren't you? So
yeah. Well, gabapentin can do both as well, can't it? Which is possibly why it's so effective. Yeah.
Dr. Swaminathan have their hand up.
Hi, Pat and Ben. This is just something that I came across when I was dealing with a child in a special school, and it was quite interesting for mum and me to notice it, but I just wondered if there's any medical explanation. He's a teenager with quite significant cerebral palsy and very bad constipation, to the point that he needed anal irrigation almost on a daily basis. He was on massive doses of laxatives before. Unfortunately, he developed sepsis earlier in the year, quite a bad gram-negative sepsis, because he was getting urinary tract infections previously. So it was a urosepsis. And he got admitted to the local hospital and was treated with IV antibiotics for 10 days or 2 weeks. Fortunately, he recovered from the sepsis episode. And the very interesting thing mum noticed is that they never needed to do any laxatives or any anal irrigation since then. He's passing stools very normally, regularly, and it's almost like his constipation has gone off from the earth. She's extremely pleased with it. I mean, it's very pleasing to hear that, and is continuing to be like that for months on. So she said, I don't know what it is. This antibiotic course he had just flushed him out, and we never looked back on this constipation. So it's a very good story that she told me, very true story. Just wondered any thoughts on that. I mean, the only thing I thought is because of the fluids he had, but to be honest with you, will it last for this long after this?
Yeah. No, it's the persistence is interesting, because I mean, we all know that antibiotics can cause the runs, but for it to be
it wasn't fun. She said there were normal stools, his normal stool pattern, many months down the line. She's very pleased. So we're not actually wanting an explanation, but it is something I thought was quite interesting.
Yes. Extremely.
I think that's an interesting point which we haven't discussed is microbial diversity within the gut, and Professor Carding from Quadram gave a lecture earlier on in the year about that, and the restricted biodiversity in children with neurodisability, and by using an antibiotic and changing the diversity or augmenting it can help with its motility, but also the other side effects maybe that Pat has spoken about. So early days really, but certainly speaking to Quadram and speaking to Cork, where there's a big microbiome centre, there's lots of studies planned in this area.
one thing to watch. I will let you know.
Great, thanks for the feedback. Thank you.
Thank you.
Okay, I'll just carry on. I just right. Okay. I haven't got very many more slides actually. I've gone through the whistle-stop tour of pain and nausea was the biggest part of it. I do want to mention GI bleeding because although it's not included in the classical descriptions of gut failure, it is something that I've come across on a number of occasions, and it's worth considering the mechanisms. The first one I came across was actually a child who had a mechanical problem. So Rose was a young girl who'd suffered a sudden cardiorespiratory arrest at home, and her father resuscitated her and she survived, but had very severe neurodisability as a result, and very, very severe dystonia and hypertonia, and also had bloating and pain and blood-stained aspirates from her gastrostomy, sometimes fresh blood stained, sometimes old blood, and we tried all sorts of things and really never we were not making much progress. And then one day her younger sibling pulled out her gastrostomy tube, so they came up to Addenbrookes in a tremendous hurry to have it replaced, and she had an endoscopy, and lo and behold, she needed a full laparotomy because her bumper had migrated, and so she had to have the whole thing redone, and her symptoms just cleared up. So it just left me thinking, I always think, well, is this something that's reversible? Is it a mechanical problem? Is there something that we can do? And it wasn't just her bleeding, but all her other GI symptoms cleared up, and it wasn't gut failure, certainly at that point. I mean, clearly there are other reasons why children can have GI bleeding, and I think it's not at all surprising that they can have coexisting gastric inflammation, and a lot of them are on PPIs. And of course, some children who develop this gut failure syndrome have a coexisting liver or gut pathology that's not neuropathic. Children with liver disease, with varices, can obviously present with vomiting. And I was just thinking of a little boy that I looked after, who I'm going to call Robbie, who had Coates plus syndrome, who, as well as having intractable pain and distension in his tummy, also had episodic bleeding, and he had telangiectasia throughout his gut as part of his syndrome. But I'm also aware that some of the children we look after who have evidence of GI bleeding, it's unexplained, and that may be because we haven't been able to fully investigate them, but it can be a feature. So I'm going to come on to, what happens at the end, because as these episodes, if they become more frequent and more prolonged and more refractory, you reach a point where all interventions have failed and you're no longer able to provide nutrition. And so this can become a terminal condition and need end-of-life care. Or does it? Is that essential? I mean, I've recently had conversations with colleagues in the Association of Paediatric Palliative Medicine about the potential for using PN in some of these children. And I think that's quite controversial, but I think it's worth flagging it. Now, in terms of nutrition, my understanding from my gastroenterology colleagues is that you use gastrostomy feeds, or NG feeds, then gastrostomy. And if those aren't tolerated, often jejunal feeds will help, and then move on to parenteral nutrition. But certainly, my understanding is that in East Anglia we don't offer home PN unless it's expected to be a reversible or short-term condition in these children who have otherwise life-limiting, life-threatening, or life-limiting severe conditions. But I've become aware that there are in other regions of the UK, people are offering emergency parenteral nutrition in end-stage gut failure, on the basis that sometimes what we think is irreversible end-stage may not be. And that's certainly true of a lot of things that we're not that good at prognosticating. And given that we've only recognised this condition in the last 10 years, we don't really know everything there is to know about it. So when we think we've reached an irreversible terminal stage, have we really? If we offered some of these children prolonged PN, would they recover, or would they have a good quality of life on home PN? And I'm asking the question, I'm not necessarily suggesting that we do it. And obviously there are issues with home PN. There's the whole central IV access and infection risk, and you need parents who are motivated and able to be trained and competent, you know, like Lenny's mum, who's immensely competent at managing central IV access. There is also the risk of liver damage, though the majority of children on PN don't suffer from it. And I do wonder whether in the future we are going to have children on long-term PN within this population, in the same way that we now have children on long-term ventilation, where 10 or 15 years ago that really wasn't something that was offered, and whether this is, you know, this is a new direction of travel. And I really don't know. I'm just asking the question. So to come back to sort of, you know, the role that to finish off where I began, really, with the role of palliative care in these children's lives, the end of life, you know, both diagnosing when you get to end of life and managing it, and with the caveat that, you know, we cannot be 100% certain that that some of this end stage gut failure is end stage, but probably is. And I think it's always very important that you diagnose dying and end of life so that we can manage it properly and compassionately, rather than just carrying on to the end without acknowledging that's happening, because it does affect our management, and it does mean that we can make that death a better quality, better controlled, and a better experience for everybody. So I'm just going to mention the two patients. Robbie was the young man with the Coates Plus syndrome, who, which is very rare. There are very few accounts of it in the literature, and none of them mention intractable abdominal pain, but basically that's what he presented with. And he became totally intolerant of feeds, spent many weeks at the hospice, becoming progressively thinner and more malnourished and losing weight. And it took very many weeks for him to die. It was a very emotionally and ethically challenging situation for all of us, for parents and for us. And we regularly reviewed the decisions that we'd taken to where we'd got to and whether there was anything different to do. And we repeatedly agreed that there wasn't, but it was a painful process. And the other child I've already mentioned was the young woman who progressed very rapidly and died. But it's not just end of life. I mean, you know, this syndrome is compatible with longer survival, and we are able, in terms of long-side symptom, to provide long-term symptom management alongside active treatment. So Sam, this young man who I've more or less transitioned to adults, he is basically transitioned, but I still have occasional contact from mum, which will cease when I retire, as she knows. But 7 years on from referral, he's still having symptoms on and off, and I think they're progressing. But he's still with us, he's still going to school, and he's gained a lot of weight. He's now 45 kilos, so he's done very well. Then the boy Ali, who was started on alimemazine, has had no GI symptoms at all after 5 years on alimemazine, and I haven't seen him for a while, but he's very stable. And the young man Lenny with the Noonans with lentiginase has also been tolerating increased enteral feeds and has also successfully transitioned to adults. So that's the end of my talk. I have a suggestion of a couple of useful resources. There's a couple of papers. This review by Lizzie Bendel and Joanna Laddie of symptomatic palliative care for children with neurodisabilities is quite wide-ranging, and it looks at a lot of different issues. Julie Hauer, who's written this book called Caring for Children Who Have Severe Neurological Impairment, and I think Ben has his copy to show you. It's a superb book looking at all the sort of complex interactive symptoms that these children can have. And she's written a number of papers as well, one specifically about feeding intolerance. So I am going to stop sharing my screen now. Final questions.
So I've got my book copy here. I encourage everyone to have a look at it. It's a great resource, actually. So thank you for signposting that, Pat. What a great talk. Thank you ever so much for your time. Does anyone have any questions? So Dr. Swanepoel, who is a child psychiatrist, so she describes in the chat prescribes clonidine for ADHD and hypervigilance, and has found it very helpful in challenging behaviour and children with severe LD. And she now wonders if it's part of the reason it works. It helps with the gut and the muscle in the GI tract.
Yeah, I always like drugs that have multiple actions. If there aren't any other questions, I do. I mean, I'd actually quite like to know from Franco and Camilla, from a gastroenterology point of view, what your thoughts are, because I've strayed into your territory.
I'll go first, if that's all right. I really enjoy these, Pat, and as you know, have struggled with this patient for a long time, and working with you has really made a difference for them. And I've learned a lot from you. I'm going to put in place what you taught me over the years, but it makes perfect sense. And we thought about these kids quite intensely in the past, and there is a point where us as gastroenterologists reach the limit of what we can do. So working together with professionals like yourself, it's game changing for these kids.
Yeah, and thank you for saying working together, Camilla, because I think that's the key. And I did have a cartoon that I included in my talks early on, which was of Mario holding on to someone saying, "Don't leave me," and that was me with the other specialists. It's me with the neurologists, me with the gastroenterologists, that's me with the community paediatricians saying, "Hang on, I need you. No. We're going to do this together."
Yeah, that's me. That's me with you. Don't leave me. That's exactly my feeling. Thank you very much for the great talk.
Thank you, Camilla. Thank you.
Thanks very much. And I had one last question, and I suppose it's looking to the future now and trying to get a picture of where research is going. And certainly with the Synapse Centre, one of our main interests is microbiome modulation, and the role of biodiversity in gut health, but also in how guts change over time. There's been an interesting talk we've been having with a team in Ireland looking into Down syndrome and premature aging of the gut and how that links with neurodegeneration in terms of early onset dementia. And I think it's such an interesting area of medicine now. So that's one of the things. And also what Naomi Burke mentioned about being preemptive in gut issues and trying to intervene earlier rather than waiting towards the end when gut dysmotility and all the problems you see can come out. And Dr. Swanepoel actually talking about psychiatry and the link between gut psychiatry and the gut, and the role of other medications, anxiolytics, which can reduce stress response, such as an interesting drug, Pat, is buspirone, which is a 5-HT1A agonist, which can be used for anxiety, but that has a good impact on gut motility as well. So I think it's trying to understand that in all these areas, we should all come together as a wider MDT, because we're all using medications which can have the same effect. But any other questions from anyone? Dr. Swaminathan again.
Can you hear me? Sorry, yeah. One last question. Is there a very high incidence of intolerances or allergies? I mean, we didn't touch on that. We just said milk feeds and then blended feed. But it's not about the disabled population, but mainly in our neurodevelopmental clinics, we see children presenting with what sounds like a borderline autism, or not sort of meeting the full criteria, but they've got a little bit of hypermobility, not so much of learning difficulties. They are fairly able, but they seem to have some intolerances and allergies. So is there an association? They also present with pain and dysmotility, constipation, diarrhea symptoms. But often parents take them off diary or take them off some other food products, such as they do a trial and error, but often it's the diary it's blamed. And the other one I'm trying to think is the wheat. Yeah, so those are the two things. So Is there a high association is my question.
I mean, I'll have to pass that question on because that obviously that isn't a population that I have any experience of looking after. They don't tend to come my way in terms of palliative care, thank goodness.
No, thank you.
Yeah, but
if I can try to answer this question, I think it's completely anecdotal. But, we do see quite a lot of these children in clinic, and as you said, parents start trial of dairy exclusion, of gluten exclusion, and some of them are effective. But this is certainly not any sort of type 1 allergic reaction. Is more delayed type of reaction, and it's completely anecdotal. But for some of these children, this does make a difference.
Okay, thank you very much.
thank you.
Okay, I think we'll probably end there then, everyone. But thanks so much for talking, Pat. It was such a great talk. Coming up next week, we've got another talk from Professor Rawich, who's a professor of paediatrics at the University of Cambridge and head of the department there. And he's going to be talking about early genetic testing in children with developmental and medical complexity. So again, a really interesting talk to come. That will be next Friday around the same time. But if you're interested, let me know. But thanks very much, Pat. And I'll, the video, this will be on the website. So thank you very much.
Okay, thank you.